Okay, we are live.
Okay, we'll start. Good evening, everyone. This is Hariom for CEBNR. Today we'll do we will do a webinar basically on uh, the value or the idea of sit to stand. We will see some amount of neurology, and we will also see about the how to use this for these ideas in case of uh, in abnormal conditions and things like that. I'm not getting into lots of details, which we usually do it for 3 years or something like that. We will give you a sort of an abridged or a condensed version of um, what are the physiological principles you need to understand before getting into these things. So I'll just have a brief I'll have just a brief presentation of what I want to say. So we are going to look into all types of standing up. It's not necessarily standing from a chair or something like that. It's standing from any lower position to a higher position. It can be from a floor or squatting to stand up, or from chairs, right? All these things we are uh, trying to look into it today. Now, we have already seen this many times, but anyway, we will start with our first question. What are the factors which forms or which influences human movements, right? What are the three major factors which influence human movements? That's the first question we are asking. And uh, you can share your answers in the chat so that we can have a discussion about that and then move on. Okay, I've got answer from Sheikh, Vignesh. Anybody else? Okay, right. I think a lot of people have. Divya Lakshmi, I'm talking about what are the factors which influence motor control. That's the point. Motor learning is not what influences movements. They are one factor. It's not a major factor also. But it is one of the important factors. Okay, anyway, so we think that human movements are influenced first by the biology. If you don't have the biology or the system, you can move, right? So there is no question about it. What I mean by here, the system is your brain, your muscles, your nerves, everything, right? The whole biology is very, very important. And whatever task you are doing, that's what influences your movements, right? Your biology alone does not influence it. It is what task you're doing. And if you're doing a task, you have to do it in an environment. So all three factors are part and parcel of how you do a movement, right? You cannot see them separately. You have to look into it together. Now, today, what we are going to do is we are going to read or discuss about this human movement. What movement we are going to talk about is the goal of sit to stand, right? So when I'm doing a sit to stand, what happens to the human biology? What movements happens? How the system produces this movement? When I do it from in an environment, what I mean by environment is the type of chair, from what height of chair, what type of chair you're sitting. Is it having a handrest or it doesn't have a handrest? Or am I talking about sitting and standing from a floor, right? All these things are part and parcel of what we are going to talk today, right? And also remember, whenever we are talking about movement, we cannot separate these three factors. They always have to look into it together, right? Say, for example, if I don't define what is the height of the chair, I can't define what are the movements will happen in the human body. That is, what are the movements which will happen in your trunk or in your leg or anything, right? It's not possible at all to define those things. So the next question I'm going to ask you is, okay, I'm going to do sit to stand, right? What are the two major mechanical goals the system should have to do a sit to stand, right? What are the things which it has to accomplish? What are the two major goals it has to accomplish for me to do a sit to stand, right? I'm going to sit and then stand. What are the two major goals it has to accomplish? Again, you can put it in your put it in the chat. Maintain the COG. Okay, what else? Anybody else wants to? Pressure on the foot is not a major thing it has to worry about. Forward translation, that's one path. There are far more simpler answers. We can easily get into this simple. So what are the other? Post-production of the muscles? Feet position is not a major issue. You can sit and stand however you want. Weight shifting, what do you mean by weight shifting? I'm not sure what is that. So if you can explain what you mean by weight shifting, I'll be more than happy. You can't maintain your COG. You don't maintain your COG. The center of gravity is a dynamic thing. So what do you mean by maintain COG? So can I explain what you mean by maintaining COG? As I told you, I'm just talking about two major mechanical goals of the system. You don't have to do trunk movements. That's the point of understanding that's the point of the first slide. Movements are a derivative of the environment and the task you are doing. You can do sit to stand without much of trunk movement. Motor planning is not what I'm asking. I'm asking you, what are the mechanical goals the system has to sort of fulfill to do the sit to stand? It has to fulfill these two factors, then only we can change in the BOS. That's a good answer. Okay, what else? Forward translation of the trunk is not what we're shifting of the stability. That is the answer we are looking for. Right. What else? Okay. I think locking of the knee has nothing to do with sit to stand. That's a very the silly answer. Now, I think there are two important things we want to understand if you are going to talk about sit to stand. One is that you are moving from a lower level to a higher level. So what I mean by that is you have to produce such a force to move against the gravity. And when you are moving against gravity in such a way, you are moving from a larger base to a smaller base. So you need to be stable, right? So these are the two conditions you are trying to fulfill. Now, if you look into here, you can see that I will try whether I can unit this picture. Hmm. Right, you can see that the person is moving like this, right? Okay, I think you can see it. You can see that he's not moving just straight up. Nobody stands up like that, right? You always have to move forward and upwards like a bridge. The bridge does not go straight up like that. It has to go forward and upwards. When you have to go forward and upwards, you have to produce force. And when you are producing force, remember your system is perturbated, right? That is, your system has been pushed from its stable COG, right? You can see here the COG is fairly large, right? It goes to a smaller a smaller COG, which is here, right? You can see this, right? And also you can see when you are moving forward and upwards, in the end of it, you are going to go in the forward direction itself. Because remember, the first class states that when your structure is being pushed by unequal forces, it keeps on moving, right? So it has to be keeping on moving in the forward direction until and unless you are producing an opposite force in the end of this in the state, so that you are stable, right? Why I'm saying this is, you can see that you are producing a force, but at the same time, you have to end of it, it has to be in the opposite direction. And remember, sit to stand, even though I have put a lot of pictures, it is hardly zero point 0.5 to zero point 0.6 of a second, right? So in a few minutes, a few seconds, not even a few seconds, few milliseconds, you need to produce a force forward and upwards, and then stop it so that you are stable and not falling backwards, right? Falling backwards is one of the common reasons you get falls in older people, especially in Parkinson's, right? So this is where you want to understand how the system tries to fulfill this goal. All right, this goal of pushing you upwards and forwards, and at the same time not falling down, because your stable, I mean your center of, I mean base of support gets smaller and smaller. Right. So even though there are a lot of people who have the Schenkman's classification has 4 stages, which I also use in my book, but nowadays I think you need to have only one phase for sit to stand, that is sitting and then standing up. That is all. You don't need to know anything else in that. And in that, what you need to know is the direction of movement you are doing. That is, if you're talking about forward and upwards, you are going to get some amount of flexion. And in the end stage, everything is going into extension. So that will be your stability phase or your extension phase. So I think a lot of people have used this way of classification also. So you need to have two phases. One is your uh, flexion phase. Another one is your extension phase. That is all. You don't have to worry about this is happening, that is happening, and things like that. Right? Why you need to know this? That is, in which direction this trajectory happens. I'm sorry, I just have to. Right. So you can see that Prakash, this
This
annotation is still there.
no, no, this is this will carry down to the next person. We need to clear it. I mean, close.
How do I clear this?
There's close is there in that option. Top last one, right
Clear,
last.
clear, clear.
Clear,
Right.
yes.
Okay. Okay. So you can see that your center of gravity is moving forward as well as upwards. So this is the one thing I think you need to understand when you're talking about sit to stand, right? The other things are just uh, uh, the other things are product of this movement. This thing has to happen. So for that, you will do whatever movements you are going to do. Right? So the next question I'm going to ask you is, because you have to move forward and upwards, right? So I have given an option of, we will have it as 1, 2, 3, 4. The lower limb muscles, the quadriceps and plantar flexors, the core, I don't know, and other. These are your options, and you can answer it, but you can't answer I don't know. That is not an option. That is just for fun we have there. So uh, so you can just type in your answers so that we will have an understanding of everything. Uh, I suppose you can understand the question. What is the important muscles for standing up, right? When you do a sit to stand, what are the group of muscles? We are not talking about one muscle. So I have written some of the group of muscles, which I think is important. So you can put in the quadriceps and plantar flexors. Okay. Others, if you say
You have to
others,
say
right. Okay. Quadriceps and plantar plexus. Okay. Uh, lower limb muscles. Okay. Right. Right. Okay. A lot of people are anti-gravity muscles. I don't know what that is. Gluteus. I have not written gluteus, but anyway, I think you're thinking of gluteus maximus as important. Okay. The lower limb muscles. Geethanjali, Kiran says gluteus, plantar flexus, and quadriceps. Ideally, ABC all required to perform a quality sit to stand. Ranchana, right? Okay. Right. So we will go back to this. Okay. This is why we told you to come up with some name. Don't come like 23D49CCO. What I'm going to call you. What, uh, please log into it and say something like that. The core and the trunk, not necessary. That's why I kept on saying that you have to move forward and upwards, right? Um, so we are going to go back to our first slide, right? Remember, the movement is the human biology, human system is moving, not your lower limb. And which direction it is moving? It is moving forward and upwards. When it is moving forward and upwards, you have to produce a force which is pushing you forward and upwards. But that is not the just issue you want to look into it. That's why I told you the second point is, when you are doing forward movement like this, when you are going upwards and forward, at the end of it, you have to stabilize yourself, right? So if you are moving in this direction, right. So if you are moving in this direction, right, and probably in this direction also, at the end of it, you have to produce another force which is in the opposite. That is, for this, if you are producing force with your probably your some amount of dorsiflexors and quadriceps and other muscles, probably the trunk flexors also. But at the end of it, you have to have even not just the end of it, even at the starting of it, you want to have a lot of muscles in the posteriorly, right? So that this is stable. This tibial part is stuck to your ground. Remember ground reaction force and the third law of Newton's third law. Every action has to have an equal and opposite reaction. That is, if you are going to move forward and upwards, in which direction do you have to produce force? That's how you need to learn. So this next question I'm going to ask you is, you're going to move forwards and upwards, right? So in which direction you have to produce force, or in which direction you have to push yourself? You can answer it via chat. backward, downwards, and posterior. Okay. You cannot have only one vector. You have to have two vector because we are moving in two directions, right? That is, you are moving forward and upwards, so you need to have two vectors. You can't have only one. That is, you can't say downwards or posterior. It cannot be like that. It has to be backwards and downwards. That's the right answer. So
Backwards and
Brijendra,
downwards.
yeah,
Backward and downward.
yeah. So you want to produce a force like that, especially when you are in the mm, when you are trying to break it, as well as when you are trying to kick off your force also, right? So and also it keeps on changing, as you can imagine. In the early stages you are trying to move forward, and the late stages you are trying to balance yourself, right? So you need to have this complex activity of all these things. And the other thing we have also forgotten is that there is also the neck, your head has to be stabilized, right? Remember, when you are always looking out for your cricket parlance, they will say that uh, the head was still, right? The head has to be still so that you can have a good stability, because your information through your vestibular, your visual system is also very clear, but also you need to be very, very stable with your head, right? So what I'm trying to say is, muscles from here to here, they all have to have uh, as a common parlance I use is, need to coordinately work to produce this beautiful movement, right? Right. So if somebody is trying to again understand what is the important muscles you want to remember, that uh, there will be a coordination of different muscles from your plantar flexors to your neck muscles. Otherwise, you are not going to stand up properly, right? Uh, so what is important is to think of it like this, rather than thinking of what muscle, this muscle. It doesn't had any value to us to think of separate muscles at all, except for probably one or two muscles we can look into it, but it gives you very little information about whether, if that muscle is working or not, whether you will do sit to stand. It's very difficult for us to give one muscle as a very important thing. But as I told you, you have to be fixed to the ground, right? And that should be on your knees. You will be moving forward, right? With your tibia as a sort of a anchor to the ground. So this anchorage is, and also remember, you're moving in the forward direction, right? When you're doing moving in the forward direction, there should be a good eccentric contraction from your plantar flexors to not, I mean, keep you balanced. Otherwise, you will sort of fall forward direction, the forward direction, right? Because you are producing a momentum in the forward direction. So you need to be controlled with that. So there may be some amount of importance of eccentric contraction on the plantar flexors and things like that. But I think you should look into this as an important thing. That is a uh, neuromuscular force has to coordinate it with the constant changing of gravity and intersegmental forces. Why do they say that constantly changing gravity and the intersegmental forces means that in every position you think of, there will be a change in the forces, and we all know that when there is a change in the forces, the muscle activity also has to change, right? When the gravity has to change, the muscle force also has to change. So don't think of it as this muscle, that muscle. It's a sort of a group of muscles which has to coordinate and work in synergistic fashion to stand up. In certain postures, certain things might be helpful, but in certain postures, not during sit to stand. If we sort of do an unnatural cutting of it, we may see some of it is vital, some of it is not vital, but you need to have it as a coordinated gravitational force I mean, coordinated muscular force, which is produced by your neurology. But anyway, some of the muscles are, they have looked into it, and you will always see that there is a lot of muscles are working together. You can see that the first muscle you have to have, you will see that the gastrocnemius and soleus, they keep on working, so that you are not falling down when you are moving forward. Anyway, so if you ask us, how do I produce this force to move forward, I would want to show you two things. And we already had sent it to your uh, through the Facebook also. The first thing I want to show you is about variability, right? How movements are so variable when you are trying to move. And this is a video which we did it in our clinic. It's not under lab conditions or anything like that. But and also I have tracked only the movement of my shoulder, even though I don't have marker or I'm not sort of half naked to have a.
That
Sorry.
it is the movement of trunk where it is tracker is placed on shoulder.
Yes, yes, yes. Right. Sorry. So the tracker is on the shoulder, and we are trying to move, see what direction the movement is happening. And you can also see a lot of things. So I will play it, and you can tell me what are the things you observe. Right? Things you observe. Don't tell me quadriceps is working or this is working, because that is not observable. And you can also see what happens to the tracker also. Right. In the last few attempts, you can see that the tracker went, it just went haywire. So leave those things. So you can see up to here. Right. So up to here, you can see it. And again, you can switch on your mic, or you can type in your answer. What are the things you observed, and things like that. What you observe, not what you infer, or sort of, as I told you, this muscle, that muscle, that's not what I observe. Correct. The Sheikh says that the first thing you will see is it's not always the perfect experiment, but this is a good experiment for you to do it at home. Core stability, how do you see core stability? What do you mean by core stability? I don't understand that word itself. So you will see that there is a variable trajectory. What I mean by that is every time I move, right, you will see that every time I move, you can see that my shoulder went in a different direction. It was not the same, right? Sometimes I bent very much, or sometimes I bent less. Sometimes I was in the later part of it, you can see I'm bending more and more because I was getting more and more tired. I was sort of uh, very unhealthy, I suppose. So I was extremely tired. So you can see that I was getting more and more into, you can see it is more straight. And now you can see that I'm getting more and more bent, right? So every time I do that, you can see that the trajectory is different.
Let me put a question in a slightly different way. In the video that you're seeing, is that the tracker shows the movement trajectory of the trunk segment, right? But
Right.
what you see is that the trunk segment movement, every trial, the trajectory is not same.
Right.
The performance of movement is same, that is sit to stand. However, the trajectory of the movement is not the same. Trajectory, what I mean, the path through which the trunk segment moves. Now, can you all think of what might be the reason, even though the same movement is repeated, why the trunk moves in a different trajectory almost every time?
I think that's a better question.
Influence of gravity is same for each movement. The gravity's influence doesn't change since the movement is performed from a same height to maintain COG, but why it changes every time? The question is why it changes every sit to, because according to us there is one normal sit to stand, right? So there has to be one normal movement pattern, as we often say. But when we observe closely, say for example, if you're observing without this tracking of trajectory, it may appear more as same movement. Muscle goes for fatigue, diffuse due to continuous contraction. Muscle goes fatigue. Second sit to stand itself, muscle goes to fatigue. You can see none of it is same. Fatigue appears after a certain threshold is reached. Second sit to stand itself, it's a different thing. And COG change with every. If you don't change, posture, lower limb fall. Okay.
Uh, um, hmm. The determinants of trajectories are variable. It varies, right? What is accessory muscle function? I don't know what it means. Right. And different experience without falling. It's not experiencing per se, Davanshi. Um, Synergistic adaptation, different adaptation. Right. Okay. The I think the important lesson for today is there are many reasons for it. I think there are two good answers. Um, one is what sorry, I can't find it now. Harsh Naiwani, am I saying it correctly? Uh,
Yes, sir, it's correct, sir.
yeah. So what do you mean by diffuse synergy pattern? I'm not getting it. So
Uh, Mr. Harsh, please unmute your mic and can you speak, explain your question?
no. He's saying the answer that it is diffuse synergy pattern. So I just wanted to know what it means.
Yeah. Mr. Harsh, can you unmute your mic and speak? Okay, I guess there's some.
Yeah. There are a lot of things which you are saying. I think the answer is pretty simple. Every time you don't do the same movement, every time you don't use the same muscles, every time you don't use the same range of motion, it cannot be same every time. It co-varies, right? There is a variation between all your muscles, all your joints across the spectrum, from the from your neck to the your calf muscles or your dorsiflexus. That is your head to toe, if you will. Right? All these things keeps on changing every time I do a sit to stand task. You are all thinking that how am I making a mistake or something like that? It happens to everyone, right? It doesn't have it cannot be just for me. It is for everybody. This will keep on changing. Again, why am I talking about this is that is why we keep on saying don't think about individual muscles. It is not going to take us anywhere. We have to think of how am I doing this movement? What are the important parameters which the system tries to do, right? As I told you, it has to move upwards, it has to move forwards. So if it has to move upwards and forwards, two movements has to happen. That is, there should be all the joints which are into flexion has to go into extension. That is all you need to remember. Everything which is in flexion has to go into extension. And when it attains extension, it cannot go beyond that, so it has to be stabilized. That is how you want to remember it, or you want to understand that, right? And for that, the brain will achieve this via different computations and different ways of doing this, using different muscles, different joint range. Every time it will change, small changes will happen, right? For that particular task, right? That means that for that particular uh, type of tool also, right? So this is the first thing we want to remember. As Sheikh has pointed out, variability is a hallmark of what we call as a normal person, or a, a, a proper adaptable human system. It means that what I mean by normal is I'm variable. Why do I need to be variable? Remember the first slide I put, right? I am variable because this environment and the task is highly variable. So whenever I'm trying to do the sit to stand, I have to be variable. Otherwise, I can't adapt to any of these situations. And you can see that even for the same task, my system is variable, right? It will not allow me to do the same thing again and again. And also, a lot of people are stuck with this idea of trunk motion, right? Uh, so I'll just show you something interesting, which you should have observed also. Um, you can see that in the early stages, you can see that I'm just starting with the trunk movement. You can see my trunk is going forward. There is no secret of this trunk movement, right? A lot of people think trunk movement, trunk movement. I understand trunk has to move. There is no question about it. But it has to move because it has to go forward and upwards. There is no secret sauce to it. You can see that as I get tired and tired, you can see how can you see where the trunk went? Can you type in your comments? What is the first movement I'm doing to start my sit to stand? You can see, can you see how am I starting my sit to stand? Can you please comment in your chat box so that we can have an understanding of it? I'm not doing trunk flexion. That is only in the first part of it. You can see that later on I'm doing what movement I'm doing to start with. You can see now I'm starting. That's where the marker also start sort of going away. Fixing of the foot cannot change. The fixing of the foot has to be there. Otherwise, I will fall down. Otherwise, I can't produce force. Remember Newton's third law, every action has to have an equal and opposite movement. Nick, that's a very small movement. Don't worry about small movements, larger movements. It was fairly simple, I thought. How is the shoulder going into flexion? The shoulder is not going into flexion. Right. Pushing your hips back. Okay, right. So I think that's hip flexion. No, not hip flexion. I'll just try to show it. I don't know why you are looking into the hip, and also I'm not sure how you are looking into the hip when you can't look into the largest movement which is happening, which is sort of funny. You can see here when I sit, and you can see which position my trunk is, right? Can you see where my how I started my sit to stand? I've sort of pushed backwards, right? Uh, I don't understand what is weightless squat. I'm just doing a trunk extension, right? I don't know what your answers are. Most of it, I can't understand what it means because we are typing in one or line, 2 lines. I think we are losing in translation or something like that. You can see that trunk went backwards and then only I started moving forward because I have to create this momentum. Because it was a small stool, I used a sort of a 12-inch stool to do this. So again, what I'm trying to say is if I have the variability of going back and then coming forward, then only I can do this sit to stand from a smaller stool for a longer time, right? So uh, again, this variability has to happen for me if I am going to get more and more sort of fatigued or weaker, right? You can see in the first time when I'm sitting to stand, you can see I have immediately done flexion of my trunk, right? There was no extension of the trunk. I don't know how you all looked into the hip. I can't see it. But anyway, when you see in the later part of it, after you can see that I'm going back and then standing up, right? So uh, this momentum I have to create. Otherwise, all my momentum has to come from my lower limb, right? So to create this or have a lesser force production, or to give my lower limbs sort of a sorry, my lower limbs go with it, or sort of give them a break, if you will. I also use a lot of this trunk movement also. That is also vital, right? That's how you create this momentum, right? Again, this is a good variability. The other thing I want to talk about today is the other thing which a lot of people uh, keep on talking about, that is your dorsiflexion. Remember, you need to fix your foot to your ground. Otherwise, you can't create force. Because as you all have read the Newton's third law, you have to have a pressure which goes downwards. Uh, பிரகாஷ், ஒரே நிமிஷம் இரு, நான் ஃபோன் பண்ணிட்டே இருக்காங்க, நான் பார்த்தேன். Right. So the dorsiflexion is a vital thing because it has to be fixed to your ground. That is vital. Otherwise, you can't move your knee, or if the knee is not moving, you can't move your. Likewise, the whole thing cannot be moved. Right. So this dorsiflexion is important. Also, it is other. It also has another function to it also. So we send this to your through the video which we have shared also, but anyway, we will just try to show it. Right. Now, this is about the understanding of why we have muscles which are elastic, right? So I have a stick in my hand. Sadly, I didn't wear a sort of a contrast color the other day. So what you can see is a stick which is sort of elastic, sort of a green stick, right? So if I bend it and then allow it, it will come back to its original position, right? If I just it will go back to its original position, right? So how do I use this? I use the same idea in your sitting position also. You can see that when I'm sitting, when you are going to be in starting position, most of the time you need to have your foot in slight dorsiflexion. You don't have to be full dorsiflexion. Even having a foot in slight dorsiflexion is valuable, because when you are doing dorsiflexion, your soleus muscle is stretched. As you can see in this moment, you can this position, right? You can see that I am sort of pressing my whole system downwards, right? Think of it like this. If I have a spring, right? If I can I shift to my camera again? Now think of it like this. If I have something like this, and if I put pressure like this, automatically it will go upwards when I leave it, right? So this is what we call as potential energy, right? You get this potential energy, and you just leave it, and it goes into extension by converting this potential energy into kinetic energy, right? So this is the other thing you want to remember why you have a dorsiflexion. You need for two reasons. One is to make the forces not just via your muscles, but also through your other properties you use it, especially the elastic property of the muscle. The other thing is you need to anchor yourself to the ground. If you anchor yourself to the ground, then only you can get fixed, right? Um, do you have any questions for what I have told? I'm not getting what Shweta is.
Hello, sir.
Go ahead. Go ahead, Krishna.
Krishna. Sir, this potential energy which you build up when you were sitting down, no, sir?
Right.
The potential energy that which has built up when you are sitting down.
Sitting down is not
Those
sitting
are
down. It is
because of
stretching of
contractile
my.
or non-contractile
Sorry, yes,
elements,
it's
sir.
not sitting down. It
You
is
know,
the contract.
because
Stretching of your
usually when we
qualities.
think of the muscles, we think of it's more of a spring.
Right. Sorry, I am not getting your question.
Sir,
Krishna, can you make your point?
sir, sir was telling that it was more of potential energy building up when he was moving from one position to another. Yes, sir.
You can't.
Hello, am I audible?
Yes.
Yeah. Can you hear us?
So, yes, sir. Yes, sir.
Right. Go ahead. So what's your question? I'm not getting your question, because your system can, when you're moving, when your gravity is, as I told you, the gravity force keeps on changing, not that the forces changes on how it is applying on, or how it is producing on your joints is changing. And because the muscles are elastic, right? They have an elastic property, and any elastic, we know that it can store energy and then release it. So the system uses those things when you are trying to move, right? Sheikh asked, does using momentum or using conservation of potential energy has implication in training? I mean, you have to, not really, Sheikh. As I told you, these are all byproducts of how you move. This is not how you have to train. But what it tells you is, if you have your joint in, that is especially your ankle joint in dorsiflexion, then the movement is far more easier to do. So if your starting position is dorsiflexions or mild amount of dorsiflexion of your foot, then it is easy to do it, as well as because your plantar flexors are also, it may work better, or dorsiflexors are working better, then the fixation is far better. So it just tells you that you need to keep your foot in dorsiflexion. That's all. Prakash, you want to add something?
Yeah. The other way of looking at it is that, say, you can get up by keeping your foot in plantar flexion also. So, so do not see dorsiflexion as some kind of essential component without which nothing, you cannot get up.
Right.
The point that is being made is keeping it in dorsiflexion is it's helpful. It makes it easier in a sense, right? How it makes it easier is because you're able to stabilize your foot onto the ground when it is dorsiflex much better than when you keep it in plantar flexion. Again, it doesn't mean with plantar flexion you cannot. You just have to put additional effort. Second thing, when you are keeping your foot in dorsiflexion, that means your plantar flexors are in stretched position. That's what is being shown, that when you flex it like this, so your plantar flexors are like that. So when you're getting up, plantar flexor doesn't have to produce all active force to achieve that. These passive force, that is elastic recoiling effect, can also be utilized better by the system. So that is what the point is. So the system does it because it can use all of it, but its role, as it was said, it's a byproduct of doing it in certain way. Just to re-emphasize, you can do sit to stand in many other ways also.
Correct. So you need to remember that, especially if you're doing sort of the right way to do sit to stand is, we don't usually do sit to stand. Mostly you do sit to walk, and you can all try it out. You just stand up and you sit and just start walking. Most of you may not keep your foot in dorsiflexion and then start standing up and walk. Especially it is easier if it is not in dorsiflexion, when you are going to stand up and just keep on walking, right? So that is one variability which you need to keep that in mind. There is no one movement which is vital. There is only one thing which is vital, that is to move upwards and go upwards and forwards. The other things are minor issues. But for us to do it easier, you can do a trunk momentum, you can do it with dorsiflexion. All these things can make the system do it slightly efficient, right? The intrinsic muscle has nothing to do with anything. Yeah, they are muscles, that's all. Uh, we are taught that it promotes symmetry, weight bearing. It does, because if your joint is already or your muscles are already weaker, and if you keep that that limb in the plantar flexion, what happens is then it struggles to produce that force required for you to move forward and upwards, and also it struggles to activate your plantar flexors, which are vital for you when you are moving. As I told you, you're moving forward and upwards, and you need to activate your eccentric contraction of your plantar flexors to have a good stabilization. So if you start like that in weaker muscles, it cannot do that. It struggles. It struggles a lot. So it may reinforce the asymmetrical weight bearing. It may reinforce the asymmetry also. There is no two ways about it. Right?
Again, I think we need to be clear that the symmetry is not the goal of nervous system, right? So we should not think in a way that just because after brain lesion there is asymmetry is coming, so we should not think that is the brain has lost its function and so on. Asymmetry is a byproduct, that when you're trying to produce a movement where with some limitation, the nervous system still produces it to stand, because there are certain systems are not performing adequately, so you get some different forms of sit to stand, right? So we should be thinking how to change these contexts in such a way brain might be encouraged to produce a better form of sit to stand should be our goal, not symmetry.
Right. Anybody else wants to ask more questions? I can't. Some of the questions I can't clearly understand, especially your knees are not going forward because you're applying backwards. I can't get what the question is. So if you want to, you can sort of make it clearer, or you can unmute and ask it. Check, we will do that. Promote symmetry, weight bearing, so attempts to you have to think of it like this. If you keep one foot, Check is asking the question, I'll just repeat the question. To promote symmetry, we will also ask one foot on the sort of a slightly raised, right? I think there may be some videos which will Prakash might be showing you. You can see that you just have to find out which leg is in more dorsiflexion. If it is in more dorsiflexion, probably your weight bearing on that limb will be slightly higher. Slightly higher. It's not that it will be always there higher, or it will be all the forces are on one limb. It will be slightly higher. That is what you need to keep in mind when you are thinking of how to promote this symmetrical weight bearing. But as Prakash was also pointing out to this, that should not be our major concern. Can you just send this
wellness trainer হয়ে গেছে
Aritra Nag, can you just keep your mic mute? So always remember there are far more things for us to do rather than just do a symmetrical weight bearing.
I have a different take on it, and I also want you to comment if you agree with that. Say if you are keeping some sort of wedge or any sandbag or on that side,
right?
I think it is what we are trying to do is we are trying to change the context in such a way to challenge sit to stand to be produced in a particular manner rather than trying to promote symmetry. Just like we are giving a high chair to make sit to stand better. We are keeping a sandbag over there. So I think we may have to look at, is it right to look at that promoting symmetry? Whether that is the goal of that strategy, or we are changing the context to bring your sit to stand a better one.
You're absolutely right in the sense that this is basically constraint-induced movement therapy for lower limb, right? Yeah. We should send this guy out.
Mr. Rethrow, you need to keep it muted. I may have to remove you if this gets repeated.
Right. So I get that, because if you are doing it in a constrained manner, after you remove the wedge or something like that, will they do a symmetrical weight bearing when they go to another chair or another sofa in their house, and will they do it? Or that is in the learning we were talking about a world called as transference, right? What you learn and then you transfer to real life situation. Whether that can happen, that is a big question. There is no question about it. I think you are right. Okay, I think that's a problem for him. I don't think he is unmuting. That's what he's also saying. Sometimes it happens for some people. Right. Anyway, there's a. I just want to show. Is Pirai here today? Pirai, are you here? Pirai or okay, because I want to show a video and he's in it. But anyway, we'll show. There are a lot of variations. Today we are going to talk about the variations. And one important variation is, as I told you, you want to think of it like this all the time when you're talking about sit to stand. I'm going upwards and forwards, right? How will I minimize this going upwards? Because when you're going upwards, you are going against gravity, right? And if you're going in a slope fashion, when you're moving upwards, it's always easier, right? So just to tell us how, just to show us in a more sort of a visual manner how this happens. Again, I have a video. This is in my site, but I don't think you can. This is a public. It's not in public, so. Can you see it? I think I have to loop it. How do I keep on repeating this? I can't do that.
Which one?
Can you see this?
Can you see need to show it in a web page only if it's a video.
Okay.
From the screen, we cannot. I mean, Zoom
all right,
cannot be shared.
Now, what I have done is, you can see that we have, he was one of my students, and we did this small experiment in our, just in our classroom, I think. So you can see that when you are sitting in a smaller chair or in a smaller stool, you can see the joints are more flexed. That's what we call as deflection. And it has to move, this center of gravity has to move from here to here, right? That is the issue. So if you have to move from here to here, again, you have to produce a lot of force. And in a slightly higher chair, you can see that he's moving from here to here. That's all, right? So he has to produce lesser force also. Now, you can see that I have just tracked it, and you can see the height is from here to here. It is from here to here. And this is why it is easier to sort of move from lower chair, from a lower chair, it is always difficult, right? Especially when you go into far more complicated movements like sitting on the floor and things like that. The other thing you will see variability in, especially in the so-called trunk flexion and things like that, is the speed, right? You can try this out also by yourself. Slower the movement, higher the energy is also required. And also, if you try to get up very, very fast, right? You can try it out while watching this video itself. Just try it out 5 or 10 times. You just try to get faster and faster. What will happen is you want to reduce your movement time. That is the amount of time you have to, it takes to do this movement, right? So what are the changes which happens when you are doing your movement fast, right? That is the next question I'm asking you, and you can share it in your comments. What are the movements which changes to make my movement time shorter, and when I'm doing it faster and faster? Am I understandable, or did you get my question?
Probably not. Okay, some
Less forward displacement of center of gravity. Wonderful. What else? Do you want to ask the question in different manner, Prakash?
I didn't get that question actually.
Okay. What I'm trying to say is you have, okay, thank you so much, Jude. If I'm standing up like this, right? What I'm trying to say is stand up very fast like this for 5 or 10 times, right? And then tell me, how am I reducing the movement time? If I have to reduce the movement time, some movements has to be lost. Otherwise, I can't reduce the movement time, right? So when I'm doing it very, very fast, some movements will go off. Whatever normal movement you think happens when you're doing sit to stand will just go off. So try it out. Try sitting and standing very fast from the chair you are sitting up 4 or 5 times and see what movement you are losing first. It will be easily observable, not what happens in your calf or something like that. It's not like that. It's a big movement you will get lost. Okay, Vignesh has answered. Anybody else? Less trunk movement. Okay. You can't have less knee movement. How can you have less knee movement? The knee has to go into extension. There is no alternate for that. But
the movement may be faster. That doesn't, we are talking about the kinematics, that is the amount, extent of movement, magnitude of movement.
Correct. Again, I don't understand dorsiflexion. What do you mean by dorsiflexion? You mean that the dorsiflexion is lost? Yes, if you are saying that, that is true. And what do you mean by trunk extension? I don't know. Again, okay. Anyway, if you see it, if you try it out in your own time also, you will see that you are, rather than doing this and will be doing this. You'll be just doing straight up, right? That is your front forward motions will get reduced, right? Again, what is the value of understanding all these things? Is the moments are so variable for each and every context. That variability makes us what we are, adaptable human being, right? And also, you should not have undue focus on each and every component, but a movement as the task as a whole, right? The task as a whole means sit to stand. Sitting back fully will be reduced. That is not what I mean by that. You have to sit back fully, right? Anyway, so that's another variability you will see. That is, you can change your speed also. In the article which I have sent also, these things are there, but they may have given you a different explanation also. So you'll have the other way also is if you're doing it very slowly, you will have an exaggerated trunk movement and things like that. That might have a lot of energy expenditure on lower limb muscles because you have to move forward sort of slowly rather than in a smooth manner also. And we also know that variability is also in the way the chairs are made. These are up to these are all there are two major variables, if you will. One is your environment, another one is your psychosocial factors. Here I have taken psychosocial factor to mean the chairs and tables also. Sorry, the environment here I mean to say is the chairs and tables also. So if you look into the chairs or the way we sit in far more different manner. You can see if you are sitting in a lower couch or with a inclination in the backward direction, you're difficult to keep your foot in dorsiflexion when you're just sitting. So when you're standing, the first you have to keep your movement, your legs in dorsiflexion, then only you can stand up. Again, why these are all important? Because when you are talking about management, what you mean by management is that if you can sit and stand from all these things, then only you have to say that you have rehabilitated. And the other thing we were talking about is asymmetry and things like that, right? This is what Prakash was also talking about. Doing sit to stand like this, right? From inside an auto to outside an auto, where the symmetrical weight bearing is completely gone and nothing to do with anything. This is far more valuable rather than doing it with a wedge or keeping one foot forward or backwards. That is more functional, and it is also more valuable also. Now, if you can see, when you're doing sit to stand from an auto, you can't do full extension of your trunk, you can't do flexion of your trunk, you can't do anything. That is why we are keeping on saying, don't think of it like that. Think of movement of just moving forward and upwards from a sitting position to standing position. If you're thinking of dorsiflexion, plantar flexion, and trunk flexion, these things cannot happen inside a car or an auto. So how will you are going to train the whole thing, right? That is why you want to understand the task, not the movements. The other thing we also want to emphasize is squatting and kneeling and things like that are far more vital for our patients. So those variabilities also has to be taught. Those are the things I want you to remember when you are thinking of planning rehabilitation for any person with any disability. I think I took a lot of time to finish.
I was about to say that's all over. Let's go.
Right. I think so if you have any questions and things like that, and if you have, I think we can also discuss because I think he is not having any PowerPoint to present. So we can have question answer on management also. So any questions, just shoot.
About this question on symmetry, it is true that some study shows that patients with less of symmetry are also having high risk of fall. Um, the problem with looking things like that is that those people who have fallen have asymmetry, but they also have had other problems also, right? Say, for example, they had a high fear of fall, greater muscular weakness, and so on. So this asymmetry is compensation, and or it's an output, right? So to it's a false, it's an incorrect conclusion, I would say, because patients who has had falling more, fallers have more asymmetry does not mean asymmetry is leading to fall. That is a wrong conclusion often people tends to come. There are other variables which is not controlled for, and on that is how I would look at it, and that is why I'm saying that asymmetry cannot be a goal. So you have also just seen that people getting out of auto rickshaw or a car, their asymmetry is the normal, right? If you try to be symmetrical, you will fall, right? So these studies that is done under a very controlled environment that did not account for contextual variations and quite a few other factors also.
Yeah.
Okay, we will take training questions a little later. Okay, so we will move on to abnormalities in the CT stand. We are going to look at it specifically in stroke. I assume most of you have seen patients with stroke. So if you're looking at patients with stroke, there are two problems they have related to CT stand. Remember, I'm saying this is the patient's problem. As physiotherapists, we may identify many things as a problem, but let us see from a patient's perspective. Uh, One thing which I want to clearly put is that sit to stand is not a major problem, in a sense that about 80% of the patients recover sit to stand fairly better in a month or so. But in acute stage, it could be a real problem. So in an acute stage, or if you're managing a patient in acute stage, there are two different kinds of problem they have. That one is a patient is unable to get up from the chair at all. That's problem number one. And some patients who are able to get up, either they get up by using their upper limb support or leaning on to one side, which is often referred to as asymmetrical, right? These are all the two problems they have. Other than that, there is no other way of looking at this problem. Now, to look at it, right, I just want to go back to what has been discussed before about the mechanical goals of sit to stand, that the overall movement is produced to achieve that goal. So I want to ask a question. Does the mechanical goals changes after sit to stand? That is, the mechanical goal is to move the center of mass from one position, from a sitting to standing. Does the mechanical goal changes after after stroke?
After a stroke, right?
Yes, after stroke. Okay, so the goal doesn't change. Then what changes after stroke? The person still has to produce it to stand, the center of mass carry from a sitting position to standing position. The goal remains same. The nervous system has to achieve the same goal. But what has changed after stroke? Base of support doesn't change. Way of achieving strategy, if strategy changes, but why? That is what we are talking. They're doing it differently, but what changes?
Remember, we gave you three parts to it. That is the biology, the task, and the environment. Remember, the environment does not change. The task does not change. The biology has changed. What is that is changed, right?
Yes, biologically, what has changed
What has
after
changed?
stroke?
Muscle recruitment. Okay, that seems to be slightly focused.
Force production. Okay. Yeah. Yes, active force production systems carrying out the task. You might want to be specific about which systems are, you know, uh, dysfunctional. All right. So if you look at physiologically, you have brain cells that are dead, right? In a more simplest form. So you have certain group of muscle, corticospinal tract or the muscle, the the nerve cell, the cell body itself were dead, right? So the information from the brain is not able to reach the pathway that brings this information is affected, right? But the brain still tries to perform the same function with whatever remaining, right? So we need to look at this way is that there are certain systems or dysfunctioning and the brain still tries to achieve the goal, right? So the first things when you look at an abnormality in a patient, you must understand that the brain still tries to achieve the same mechanical goal with some system not functioning well, right? So the output that we see, which I mentioned, both not able to get up or leaning to one side or taking support to get up, these two problems are results of brain trying to function with limitations. That is, it is the combination of, but not only the primary impairment what is lost, the brain's attempt to function with certain functions are lost, right? So you need to be clear that this is the brain's attempt to produce with whatever that it has. So let us say if take the first problem of braination is not able to perform. Now in the mechanical goals we have said that a movement has to take place and the movement has to be stable and safe, right? This is the function of it. Now when the brain is trying to get up, right, with motor system primarily involved, that it's unable to produce force. Now what does the nervous system would perceive? These three goals, stability and safety, is achieved. Just I want you to try to visualize and imagine, and the brain is trying to produce this achieve this mechanical goal with certain limitations, force production or force grading, right? Does the brain would still perceive safety, safe and stable?
Yeah.
Yeah. So if the brain perceives that it's safe and stable, then the movement will be attempted, right? But if the nervous system perceives that it's not stable, it's not safe at all, meaning I'm going to fall. Remember, it is the perception of the nervous system. They fall or don't fall, they wouldn't know. But if they perceive that they will fall, then they will not attempt. So one of the reason, if you look at patients, they are not able to perform sit to stand, is that the brain perceives that the movement cannot be performed safely, right? So that I want you to look at this way rather than looking at knee extension is not there, hip extension is not there, and so on. Irrespective of the capacity, whatever it is there, if brain's perception is that you're going to fall, I cannot do. If they perceive that, or previously patient has attempted to get up and they fell down, right? Now the brain's understanding is that it doesn't have the capacity, they will fall.
Sorry, there's a question, but still there is a problem of sequencing, timing, finally coordination.
There is a problem with sequence, timing, and finally coordination. Yeah, like I said, like it has been discussed before, sequence, timing, and coordination. That is the secondary level problems. Once the nervous system is able to produce it, the nervous system focuses on producing the actual task. not necessarily with the same sequence or same coordination, right? So if the nervous system is trying to produce what it has been producing before and it has a problem, it won't just shut down. It will still try to produce it by using some other coordination that is possible. There are set of possibilities that is available. One of the possibility is not possible at all. So we are discussing about the first one. If the nervous system perceives that with irrespective of whatever combination that I use, that this movement is not possible to perform safely, right? Then the nervous system does not produce a movement. The patient will say, no, I cannot get up. And somebody is holding and getting up, then he will do, because at that time he feels stable. I mean, he feels safe, right? So this coordination is right now what we are producing, these kinematics, what we have discussed before. That is what we call a preferred pattern. That because of your repeated practice, that's producing an outcome that functions clearly, or that is useful function. So it has been repeating. Now after stroke, when the nervous system tries to produce same, right, it is unable to, or whenever it tries to produce same, the safety concern, stability is not met. The person is trying to fall. Say for example, after stroke, the patient is trying to get up by going forward, but he's not able to fix his foot onto the ground. But the nervous system producing the same muscular, the movement pattern, right? It's trying to go down, but at the same time, the foot is not fixed on the ground, unable to fix, and he falls down. He feels less stable. So therefore, what the patient will do, the patient will not do the same thing again, because he's feeling like he's falling. So he has two options: either don't do it at all, or do it in some other way where you still feel safe and you can still move it. So instead of going like this, the patient will move like this and tries to get up by holding on to the chair.
Right.
Can understand. So you have to learn to look at the problem from the nervous system's perspective, rather than looking at trunk flexion, or because brain will do whatever it that comes as a better option, because brain's focus is getting up, not trunk flexion forward or this. If that is not possible, it still focuses on getting up. Can you understand? So these two, this asymmetry often discussed. I think we shouldn't see it as asymmetry. We should see is this the current available option for nervous system to get up safely. Right?
That is right.
Yeah, you are about to say.
No. Go ahead.
Right. So that option, we should be careful as therapists telling the patient not to do, because this is the patient perceives that as a current best option. If we simply say don't do it, then the patient left with no option. So we should be careful. Is there any other option available for that particular patient, considering their severity and so on? If we find there is a better option, and then if the patient performs, is able to do it, then they can do it. And if you are offering another solution and this patient is totally unable to do it, we can't just for the sake of the right option, we cannot be forcing that on them, right? You can offer another option. By that option need not just be by telling them. We can change options by modifying environment. There are many ways to do. We will get to that later. But what I'm saying, the principles of treatment or the reasoning that you have cannot be about preventing everything that is appeared to be normal, abnormal. So yeah, I want you to see that this is patient still tries to get up. This is the available option they're trying to get up. This is what they are able to do. Right now, we have to see, is there any other way we can make it better? Right. So do not see that as something abnormal. This is what the nervous system has selected as the best possible solution given the current context and capacity. So if you're having any questions so far, you can ask now in terms of understanding abnormality.
Sheikh has put a question. So from the training point of view, we can nudge the system to do the task, but we can't really dictate how to do it, is it?
Yes, because even the nervous system doesn't have a right way of doing it, because it's just our the illusion that there is one right way of doing it, right? We just have to modify the system constraints in such a way and see if the brain is able to come up with it. And remember, brain does not have a solution in hand, right? With this system. Yes.
Sorry. That's why Preeti also was talking about there is no motor programs in as such in your brain. So if you switch on sit to stand motor program, then that will not be activated. And that is not how the brain works. We are very clear of that also. And also we want to remember that if there is a program for all the movements, we will not have enough space in the brain, it seems. So program as such is not a solution. Good.
And in that video, what you have seen, every time there is different movement trajectory is coming, it is also an evidence that brain does not have a predetermined program. If there is a predetermined program, then you will have one line every time you do, because you're activating, it's just like you're typing it in your Microsoft Word. You type A every time A comes because it's predetermined. But in sit to stand, it is not coming because it's not predetermined.
Sir,
Yes,
sir. So when we treat a patient like stroke patient here, and we try to make them to sit or stand or do any specific activities. So what are the, when you say, so when we say assessing a patient, we have to understand what are the possibilities that that nervous system is able to do. So one thing is how to understand that. Second thing is, when in the treatment perspective, on the, even also in the assessment perspective, if you see, it is again creating various context for the nervous system to try out what it can do. So in a way, if you see assessing a patient with the nervous system disabilities, identifying all those different contexts will be the key, right, sir? So
yeah, here I'm if you're saying assessment in a traditional sense, I do not
no, sir.
recommend.
Understanding. That's what,
If you
sir.
say
Understanding.
reasoning, I would agree, because the assessment, whatever, if you're testing for muscle strength, sensory, or also, this will not give us any
Anything.
proper understanding of why it is. What I'm talking about, your reasoning.
Yes, sir. The context, understanding the context which the nervous system is able to do, identifying different context where that specific nervous system is able to achieve a task will be the primary part of assessment, or reasoning, as you say.
Reasoning would be the more appropriate term rather than the assessment.
Even then, these are all. I think the easier way to look into it is the variability of the solutions which the system can promote, rather than reasoning out or things like that, which might be
reasoning in the sense, I was not saying about brain is reasoning it out.
No, I understand. Okay. A lot of people are asking guidelines and protocols. That is not how we work. You can't ask questions like that. We are not answering those things.
Right. So to summarize what we have been discussing so far, we've said there are two major problems that we see. One is patient is totally not able to get up. Another one is patient is able to get up, but he gets up in a different way than what we used to be. I was trying to explain that both these things should be seen from the nervous system's perspective of available options, available solutions. And when nervous system chooses a solution, it often prioritizes safety first. Nervous system would not select a solution that appears to be very unsafe for the system. And one of the safe option is not doing movement at all. Right, that so you need to understand that if the patient is so if the patient is feeling so scared, the nervous system chooses the best safe option is don't move. Right, so we need to keep that in, because this is the reasoning we are going to take it if we are going to develop interventions also. Right, the other option is if the nervous system uses the similar movement pattern as it used before stroke, but if it becomes unsuccessful, the nervous system selects other available options. That is what I was saying, that when you're trying to get up using the previous movement patterns, but if you are not able to get up because you are not able to fix the foot onto the ground because the motor system capacity is lower now nervous system chooses a different option. Okay, if I can't put it on this leg, let me use my another leg to get the safety and then get up, and I can do this by leaning onto one side, right? So that is the next option nervous system chooses, and we need to understand this. There is a reason why it is chosen, and it serves the purpose of safety at one level, but it may not serve the purpose of functional at all level. Now that is where, as physiotherapists, we needed to figure out how you can achieve both of on both sides, a bit of both in some cases, or best of both in some case, depends upon severity and so on. But as physiotherapists, we need to enter that level and see how you can get both, if there is a way to get both, that is safety and the function.
Okay, I think that's a good point.
Preeti, yes, the precision of movement is it's a, again, it's an illusion. It doesn't exist. Precision means there is a predetermined accurate number is there, except that we don't have it.
And also, there is no need for precision. If it is an upper limb task, you may need a precision in terms of uh, writing within the lines or things like that. Here, the targets are quite large. You just have to stand up without falling down. That's a wide range you can work on. So you don't need to worry about any of these things. You just have to worry about only one thing, that is completion of the task.
And also this line of reasoning comes, I think, is because of the output of the movement. A lot of people see the output of the movement and think the output is precise. So therefore, the parameters also be precise. Say, for example, if you look at Malinga, if he bowls Yorker, he can hit the same spot repeatedly, precisely, if you want to use. But he may not be using the same movement pattern to hit the precise one.
Correct.
Right. So that is what we need to understand. The performance can still be very accurate and very precise.
Right.
But the movements that are used to produce may not necessarily be the same.
That's why if you go and do the same experiment, what we did for sit to stand on Malinga, you will see that every time he uses a different trajectory. His position of the wrist, which can be changed, the position of the shoulder, all these things will be very different. It may go more and more horizontal when he tries to put a Yorker. That's what you want to remember. Again, Juhi as a question. I think you need to, I will ask it so that you can answer. So if the patient is leaning on one side, how do we correct it or modify it? That is asymmetry again.
Yeah, like I said, the background is you have to look at that as the nervous system has selected that particular movement pattern for a reason. And we should not start questioning the nervous system's wisdom of selecting whether is it right or wrong, right? But yeah.
But sorry, I think you need to have a far more broader question than that. Who cares if they are standing up like that, right? Of course, it has its own advantage and things like that, especially if they are in chronic patients, don't worry about it. I'm going to ask you, any of you, a question which we ask everybody, whoever attends our course. How many of you have asked your patients, can you sit on the toilet and get up easily? Or do you need, where are you going to the toilet? Is it in a stool or a chair? They made it for you, or are you squatting on the toilet? Or are you sitting on the floor and eating? Is that how you used to eat? Have you asked any of those questions to your patients, right? So if you have asked, how do we train those things? So that's the question we are asking them. Okay, Sheikh says yes. Right. Anybody else? Okay, I think Senthil is. Thank you for the honesty. I understand you have a modified bar and things like that. We're not talking about one patient. We're talking about your patients. Yes, with an S. Right. So, so if at all you are thinking of like that, ask those questions whether your patients are able to fulfill. Also, this is one thing we also have found out. Prakash will explain it in a bit, I suppose. The other thing which we commonly see that is lot of patients come in a bike, right? They sit in the back and they are brought to the clinic, right? And in my lifetime, right, I have never seen a therapist teaching a patient how to sit on the motorbike, right? The patient themselves learn it. So these are the things I think you need to be worried. And also, as I said, there are lots of deep knee flexion activities which commonly are not fulfilled by our patients also.
Before getting into that, I just want to give a few more clarification on the question asked by Juhi. That because this is it's a common question, and also common question where people misunderstand when we say that don't correct it.
Right.
So to the answer to that question, should we correct or modify? The answer is yes and no, right? So we should attempt to correct it in some circumstances. So before correcting, we need to understand why the patient is doing that. See, if you're looking at an acute stage, many patients may attempt it in a way that first or two times they've tried to do, so they've fallen down or they feel like they're falling, so they attempted this way, right? So one reason is it is because of fear of fall. So if that is the primary reason that is deriving them to move that way, so we needed to encourage the patient, or we provide some physical support, or we tell them that you try now, I'm standing nearby so you won't fall. It's just changing the circle context. Previously brain has chosen the another movement pattern because it's concerned about safety. Now you are addressing that concern by providing physical assistance and standing there, or verbal encouragement, making them feel try again, right? So we can try at that time and see if they're still able to do that. So that time it might very well work. But if you're thinking that if you're seeing this patient 3 months later or 6 months later, right, where the fear of all other concerns are moved, and this has become a more easier ways of doing this, and they have gotten used to. There are adaptations local from local muscular adaptations to more broader general adaptations in the nervous system that has taken place. We talk about plasticity and many things. So at that time, they have already learned, and we cannot simply say I will make them unlearn, because that's not very simple.
Right.
So that time we needed to accept that they have moved towards certain level. Now it can no longer be done. So that's how I put yes and no. Okay, so next we are moving on to the performance, sit to stand performance, the variability of sit to stand performance. As it has just been pointed out, sit to stand is often discussed in context of getting up from a chair, right? Because most of the studies, if you look, biomechanics studies are all done on getting up from a standard chair. So even including this phases, what Shankman has described, and everything is getting up from a chair. Then we have sort of narrowed down our task. Even our training also often focused on getting up from the chair. But this is not for lack of knowledge. I think it's lack of perspective, because we all, if I say that we all have to get up from different chairs, everybody would say yes, of course. But at the same time, we rarely examine patients' performance getting up from different chairs. Now, this is it's an irony, if you have to say, that why we are not doing this is because one thing is that we are reading in textbooks, and everywhere they talk about getting up from chair. You take any neurological textbook, except the one that is written by Hariom, right? Most of the textbooks on stroke talks about getting up from chair. So we derive that knowledge from there and we just use it without thinking the other way around. So the point is, sit to stand from the chair is it's not enough. In patients' home, they have different types of chair. I work in a rural setup. Many of the time, my patients say we don't have furniture at home, right? So there are other parts of the world. People live differently. They don't have furniture at home. There is no question of sitting up, getting up from the chair. They have this cot that is made of this rope, this village type thing. So they have to get up from that. You know how it is, right? If they have a bed that is made with the rope, that it just goes in. It's far more difficult, even for a urban. I'm a person who grown up from an urban environment. It is very difficult even for me when I go visit their home. So these are all, there is quite a lot of contextual variation in terms of types of chair that is used, height of chair, the cushion, and uh, uh, the backrest, and so on. Other than that, in our context, sitting on the floor, squatting, that is another big problem. Big problem in the sense that independence in sit to stand from chair will not automatically lead to. The answer is so obvious because the environmental or contextual demands are very, very different, right? So uh, that means we needed to, when it comes to intervention, we got to train for performance one, sit to stand, and we got to train for variability two, right? Unfortunately, in clinical practice, we focus excessively on performance of a task, a motor behavior, but often leave out the variability for patients to figure out themselves. And our clinical environment doesn't have that much variability that they could do, right? So we needed to, we should not just leave the patient to figure out themselves in terms of variability, go and try at home, and they won't practice at home because they will have the same problem again. So we needed to try different variability also. So a simple example is practice with different types of chair height variation, chair cushion variation, sofa, and so on. You can, if even if you don't have sofa, you can create an environment, simulate an environment of a sofa by keeping few pillows on the chair, or trying with a low stool, low chair, and have some cushions and so on.
I just want to interrupt you and interrupt you and add only one thing. Remember, the variability should not be dictated by you. Variability should be dictated by the patient's need. If your patient does not need to sit on a sofa or sit on a low stool or even floor, you can not do it at all, right?
Yeah. So in a clinical encounter, this is how often it happens. You see this problem commonly in acute setup, right? Mostly in people who are working in hospital often come across it. So commonly the sit to stand is performed on the bed or the plastic chair that is there, and the patient is able to perform that. Then we move on to walking and other problems, right? So what we are saying is, don't just move on to it. You needed to so if at all we are talking about assessment, this is what the assessment should focus on: the patient's performance in various contexts. And then think of how we need to first consider that as a goal.
Right.
And if you ask me how to train it is fairly simple. You just have to use these different environment or the different shares and so on, and encourage patients to get up. Again, when you're encouraging to get up, do not focus on movement quality, accuracy, or precision. Focus is on the goal. Patient will figure out in most cases how to do it in a more efficient way.
And also, we want to just add to that is that sometimes you need to gradually go to that environment. You can't straight away go to a squatting or something like that. That's one thing we want to emphasize. Some people might mistake it that way. And also, you may have to give assistance when you are doing it, right? For that reason only, we need to understand the trajectory of the movements and the trajectory of the whole task and things like that. because if you see squatting, most of the movement, if you see squatting to standing, most of the movement will be in the upward direction rather than in the forward and upward direction, right? So you need to know in which direction you want to give assistance, whether it is like this or like this, or whatever direction you want. For that, you need to have the understanding of the trajectory and how the movements are happening. All these things are valuable in that particular situation.
And this is exactly where a lot of mistakes are being committed by physiotherapists, because the way they support is often contradicting or how the mechanics should be done. Say, for example, they will ask the patient to hold like this
Right.
and get up. Now, this is again coming from poor understanding of the mechanics, right? Because we are talking about center of mass being, transported from sit to stand. Holding this like this is often makes it more complicated than actually it is. The one why we are asking them to do it's because we have seen people doing it. We are asking them to do, right? There is no this selection of this exercise or selection of this suggestion to hold is does not come from the reasoning based upon mechanics.
And
Right.
also remember, also remember that if you have your hands free, then only you will make it more uh, confident for your brain. The brain wants to have your hands free when you are shifting or perturbating your COG, because it wants to hold to something if it is going to be perturbated. So it is vital that the hands are free rather than holding it to something like that.
And the other common errors done is the physiotherapist often stand in the way of
Right.
forward movement of the trunk. That is, physiotherapists often stand here, so the patient often goes like this because you are standing in front and you are actually you are preventing the trunk from moving forward. Right. So this is also a common error which I have observed what they do. Second, the another one is that physiotherapists often hold at the knee but not with the purpose of fixing the foot onto the ground. They
Right.
just use the knee to straighten it. Now you can't straighten it on a base that is not fixed. So you have
Right.
to give a downward pressure first so that you can fix the foot, that is the foot onto the ground. And then when they're getting up, you can focus on extending it.
That's the reason why we were talking about in the first place. If the movement is for upwards and forwards, right, upwards and forwards, in which direction you want to give an opposite force? The opposite force should be downwards and backwards. So the downward force should be from your fixing your tibia, right? So that is vital for us to understand.
So the understanding of mechanics should guide you in terms of how you're giving physical assistance.
Correct.
That is
It is
where
not
the
to.
mechanics
It is
done.
not to just correct the movement, if you will, right?
And also, it's not for an academic purpose alone that we know the mechanics, but when it needs to be put into practice, and in the practice is that how we give our physical assistance. You know, to push them in this direction and to control a particular movement and so on. Right?
Okay. So I think that's it from us for about sit to stand. So we'll just take one or two questions before wrapping this up. If anybody wants to ask a question, otherwise I will wrap it up. Is it all right, or anybody from the YouTube also? Anybody wants to ask any questions before we just okay? All right. So Prakash, do you want to summarize and finish off?
Yeah. Okay. So I just give you a few points for you to as a bottom line. First is that if you're talking about a task, we needed to understand what are the mechanical goals of that task, right? Say for exit to stand as a task, it has a function, yes, right? But it is from a task level also it has goals. So if you look at that, the center of mass from a sitting position has to be transported to a standing position. And the point we have been emphasizing is that the brain controls as a whole movement. So we should resist our temptation to break it into parts and see. Right? Brain wants to go from sitting to standing or standing to sitting, and it does it by any way that is available, the best possible solution at that time. Whether there is a good trunk flexion, as you can see, we have discussed that it can be done with without much trunk flexion also, depending upon the need. So that's why we should not focus too much on flexion extension and so on. Focus as a whole and consider how the mechanical goals are achieved. Remember, performance and safety, that is stability, is always important for any task, and we needed to see that brain prioritizes these two things, and you need to know how it prioritizes. And second is when it comes to abnormality, again you need to think that the brain wants to achieve these mechanical goals again with after stroke, right? When it attempts to do that using the same movement patterns, and often it becomes impossible, in a sense that either it's not safe to do that, patient tends to fall, they try to do it. When that happens, or the task goals are not achieved, and that happens, the brain comes up with a different solution, whatever is available on that context, right? And that may not always be the best solution. So how we can do that, how we can create a situation for a better solution is you change the task, you change the environment, not necessarily physical environment, even psychological environment. See, when I said that the brain is coming up with a different movement pattern because it's not considering it as to be safe, right? So even if we are there physically over there giving reassurance, can also change the patient's perception of the task, and they might try to perform it now because they feel that they are safe now, they may not fall, right? So you can modify the task, modify the environment, physical, psychological, social environment, and encourage the patient to perform. Again, there is focus on precision or one particular movement pattern. We shouldn't be focusing on it, because as it is repeated, brain will come to find out, the patients often figure out the best way of doing it. We need to keep in mind the goals of that task only, and give them an environment, less constrained environment, identify where the constraints are coming from. If it's manageable, if it's changeable, as physiotherapists we will change. And providing physical assistance should be guided by our biomechanics understanding of the task.
Right. Also, I want to emphasize that cerebral palsy and this is all same. There's no special need for cerebral palsy. The cerebral palsy, only thing you want to remember is you need to have the child attention. It has to making it do it actively is far more difficult than in a patient who you can just tell him and he will listen. So you can have toy-based or game-based, that kind of thing is vital, and the mother and father should be there. And those are all what is different between adult and in children. Otherwise, there is no much of difference. Also, you can make do sit to stand by making the child sit on a lap of the mother or father or something like that, rather than just a chair or something like that. And also, don't again, the one thing I want to emphasize is don't try to normalize anything. There's nothing to normalize. So if you do that, you will always fail. Try to promote movements that will make it better. Right?
About that, many approaches available, which one to choose? My response would be, there is black and white TV, there is color TV, there is LED, and there is smart TV, Android. Which one you want to choose?
Yeah, that's a good
right?
question.
That's how you will see. Just because something is old, you don't want to buy black and white, right? The approaches that you stated are equivalent of black and white television. It is of no use.
Okay, so thank you folks for participating in our webinar on sit to stand. Thank you so much. See you some other time. Bye-bye.
Thank you, sir.